Thank you for joining us today and welcome to the Penn State College of Medicine COVID-19 and Regional Skilled Nursing Facilities ECHO series. That's a mouthful on a Thursday afternoon. And again, we're delighted to have you join us for today's session. My name is Jackie. I'm a member of the ECHO team. I'll be facilitating today's session. A few quick announcements before we begin. Please go ahead and enter your name and email address in the chat function for our record-keeping purposes. We ask that you stay muted unless you're speaking. You can use *6 on your phone or the microphone icon on the bottom corner of your Zoom screen. You're also able to use the chat for communicating. And if you have a webcam, we certainly encourage the use of webcams. We realize that question and answer time is important to you. We try to categorize and address as many questions as possible throughout the session, but we do follow up with any opened items afterwards. Please remember that if you're discussing a case or a specific situation, no personally identifiable information or PHI is allowed. We are recording these sessions and we share all materials and recordings after the session. In the spirit of ECHO's all teach, all learn approach, we're on a first name basis during the sessions. Today's session is going to include a discussion on lessons learned by visiting nursing homes by Dr. Nicole Osamala. And during the lecture, again, please feel free to put your questions into the chat. We have a team of specialists from Penn State Online, and they'll help field questions, but we will continue to address those same questions during the discussion if need be. And remember, it is all teach, all learn, so anyone can share both questions and answers. And even if you're simply looking for input from your colleagues today, feel free to put that into the chat. Before moving on to today's lecture and discussion, I'd like to hand things over to Jessica Byler. She has some information to share on an upcoming opportunity.
Hi everyone, good afternoon. We wanted to invite this wonderful group of participants to a new ECHO series that we are a part of. It's called the National COVID-19 Action Network. Their goal is to get COVID-19 management information out to every nursing home in the country. You can see kind of a list of some of the goals that they have. It's really things that we want for all of our nursing homes to be able to prevent COVID, to help treat patients with COVID, and make sure that the staff has the knowledge that they need to do their job, protect themselves, and take care of their patients. So this project is funded by the Agency for Healthcare Research and Quality and with the Institution for Healthcare Improvement. And so what that basically means is there's a COVID-19 component information on COVID-19. And then there's another portion that's a quality improvement portion to the ECHO series. It is 16 weekly sessions. So 16 sessions right in a row, 16 weeks. They are 90-minute sessions. The nursing homes are required to participate in at least the first 60 minutes. But if you are able to attend 13 out of the 16 sessions and you're able to have 2 people from your facility attend, you are able to get $6,000 in compensation for your facility, which is pretty nice. Sorry about the dog. We are starting the week of the 11th, or the week of November 9th. So it's coming up pretty quickly. We don't have a solid start date for you at this time. But we would invite you to reach out to us, to email us at echo@psu.edu if you're interested, if you have questions. We will be sending you an email with information as well. Now, to that end, since we don't have a date or a time selected, Jackie is wonderfully going to put a poll up for you to answer, because we are interested in trying to accommodate your very busy schedules and workflows as much as possible. I can't guarantee that we will be able to, but that's our goal in bugging you with these questions. So.
Well, thanks, Jess. So I'm going to launch the poll. 4 quick questions. Please feel free to answer all that are relevant. They should be quick and easy. Are you seeing the poll?
I don't see the poll. Do I need to stop sharing? Oh, there it is.
All right, there it is. And you know, in light of what Jess just mentioned, I know you've already put your name and email address in the chat. So if you are interested in additional information, just go ahead and add that you would like that info sent to you in the chat. And just while they're completing the poll, it looks like Chris Horn has a question. Would assisted
Yes,
living qualify as they're not a skilled nursing facility?
that is an excellent question. I think you have to be on the list of nursing homes in order to qualify. But if you want to send me the name of your specific nursing facility, I can check to see if you are on that list.
So I'm going to wait a minute or so. We have about 31 people online today, and right now about a third of you have responded to the poll, which is a really decent number, but we'll try to get a few more of you to respond before we end that poll and move on to today's discussion.
Thank you, everyone.
So last chance, another few seconds, we'll end the poll, and we will move on to the discussion. All right, well, thank you very much. I am going to end that. If you do have further input, please, again, you can email us at echo@psu.edu. And with that, I am going to hand things over to Dr. Asavala, who will share lessons learned during her visits.
Hi there. Good afternoon, everyone. It's fun as the weeks have gone on. I recognize more and more of your names, which is a good thing, I think, because it means we're getting out there and meeting people at our different nursing homes, assisted living, personal care homes across our region. As many of you know, I'm the lead clinician for the South Central Regional Response Health Collaborative. And we thought as we were planning out these sessions, this would be a good time to kind of do a look back. While it seems some days are really long, also the time has gone by really quickly. And so we've learned a lot as we've met with all of you, and thought we'd share what we're learning and also just have a conversation about what you're seeing as you're experiencing COVID in your homes. Next slide. So a couple of topics that I want to hit on. I kind of identified 5 critical elements to COVID-19 mitigation in nursing homes. And this was not entirely apparent to me when we first started going out. We had our little checklist form that we followed, but I really can give great examples of kind of the 5 things that I think are critical to be successful in bringing an outbreak under control. Also, I thought it'd be a good time to contrast changes in PPE utilization from early summer to current, because it has changed, and that's probably one of the biggest areas of concern we've identified as we've revisited sites with outbreaks more recently. And then also talk about barriers the RRCP has observed at nursing homes that contribute to inadequate preparation for COVID-19 outbreak. And this is not by any means a slam on all of you working hard in the field. This is kind of like the inherent stuff that even with all the guidance that you've been given, things that are outside of your control that make it really hard to manage an outbreak. And I wanted to have a conversation about that, because I know, if anything, we've been collaborators and advocates for one another when outbreaks occur. Next slide. So just a couple comments about the RRCP. I think you guys are all pretty familiar with it, but just to kind of, give you a feeling for where we've come from. This was a new program. None of these elements were in any way, shape, or form collectively working in one direction in even the beginning of July. This was really a rapidly established program to bring concrete support to long-term care sites across our region. And by that, I mean, yes, we have a team of internal resources from Penn State, but they weren't doing this work when the grant began. We kind of all rallied and in some cases took on a totally different role than what we do on our normal work. In addition, you know, prior to the grant, we didn't have concrete ways to help. And what we found was that, yes, our homes were looking for advice and consultation, but they needed like staffing, PPE, testing support, and we were able to bring that. And so gathering all of those resources to bring to our homes was a key part that took some time to put together. Another thing is that, you know, what they laid out in the grant, we've really had to adapt and evolve. It wasn't just exactly what they said is what was needed. We really, when we got into your homes and spoke with you, we realized that some of what was laid out in the grant maybe didn't match exactly what your needs were. And so it's been a continuous quality improvement project for us, really. Also, there are certain things that are required within the grant that we're expected to fulfill, that we're held accountable for. And we manage that in addition to unpredictability of where outbreaks go, because we head out on rapid response visits. And so we've really tried to balance what is required from a grant perspective. And many of you have visited with us twice already, with the emerging and urgent needs of a building that has an outbreak. The other thing is prior to this grant, we didn't have any sort of collaborative effort with the state, and with the RRHCP, we have meetings twice daily at 10 a.m. and 3:30 p.m. for an hour, every day, Monday through Friday, to ensure that we're all on the same page with buildings that are having troubles and making sure we're getting the resources to you all. And that is also, and then we have 2 meetings on Tuesdays and Thursdays where we just speak as clinicians trying to learn from one another as well. And really we do all of this trying to balance at all times our resources and needs so that we make sure that we have resources when a home does have an outbreak, that we don't have too many diverted to one area that we can't quickly pivot to another. Next slide. So this is imaginary. It's kind of a mishmash of experiences that I've had, but just to kind of give you an idea of pretty much what we hear every day. There's at least one home that we're hearing about every day that has outbreaks. So these are the types of scenarios that you're probably familiar with too. This scenario, there is a 180-bed nursing home. There's 290 staff. Their PPD is a little on the slim side, 2.9 to 3.1. As you know, you need to stay over 2.7. Prior to an outbreak they experienced in late July and August, it took them about 6 weeks to bring it under control. They ended up having 64 residents and 44 staff with COVID. During the outbreak, the PPD fell below 2.7, and as a result, they couldn't dedicate staff to their green, yellow, and red zones. And the RRCP provided agency crisis staffing. During the outbreak, they also identified issues with gown supply, N95 supply, and required multiple PPE pushes from the state and the RRCP. During the assessment, we noted multiple infection control issues during a rapid response visit that included double gowning, gown and mask reuse, along with no dedicated break rooms, bathrooms for staff in each zone. And also they had lab supplies and a lab capacity, but the turnaround time was at 5 to 7 days. So this type of scenario was pretty common early on, and we still see it a little bit in the outbreak, in our outbreaks more recently. And just a couple of comments about it. So, and I'll highlight this when we get to some of the updates in the PPE guidance. This by no means reflects the fact that this building, they were working so hard to bring their outbreak under control. These numbers can happen even if you are doing everything you possibly can. Because when it comes down to it, when you have an outbreak, the type of needs you have in terms of staffing and PPE boggle the mind. When you, hospitals would rarely go through as many gowns as a building that's an entire yellow zone, for example. It's huge. And this is not the type of resources that nursing homes are normally equipped to handle. And so while this scenario has played out many, many times as we've assisted sites, what I want to say is that I don't think it reflects at all on the hard work of the staff and the leadership of the buildings from day to day, but it's a situation we find ourselves walking into almost every time. And this is what we're focused in on when we come in, and we're trying to figure out how to bring the conditions under control for the building. And so the things I'm going to talk about next are things we've learned as we've worked with all of you on how to try to stabilize the situation during an outbreak. Next slide. So here are the 5 things that I think are absolutely critical to manage a COVID outbreak. And I say this because the chances of one of you having a positive staff member and therefore qualifying as having an outbreak, a staff member that comes to work asymptomatic, right now with the community positivity rates that we're seeing, it's highly likely that you may encounter this. So these are the 5 things that I think are critical. Having lab supplies available. So when you find out you have a positive, the very first thing we want to do is test everyone and understand where else is it in the building, and, and start cohorting. When you have to wait 2 or 3 days to get lab supplies, that is a huge problem. So the first thing we're looking at is, do we have staff do we have lab supplies? Do we have staff to swab? Many of our homes have just barely enough staff to cover the patient care needs. They don't have a team of people that can go around and swab, 200 residents and another 250 staff and get it done within a day or two, because that's not your normal operating procedure, yet that's what is required when you have an outbreak. And also that the lab you have has a quick turnaround time. You all know when you're sitting around for 5, 6, 7 days for the labs to result, only to find out, oh my gosh, I had 12 residents on 3 different units that were positive. You know that you're going to go through another week of pain with additional positives, because you've had people that are positive that have been on a unit for a prolonged period of time that were positive, and just increasing the chances that there was transmission. The second critical element is rapid cohorting, and you can only do that after you've done your testing. But once you have those test results, the positives move to the red zone, the exposed folks go to a yellow zone. One challenge we've seen is that, and I totally get this rationale, that the roommate was negative, the other one was positive. I don't think I should move this person. They're definitely going to be positive. What we dealt with in the spring was kind of that, but it was because we didn't have enough testing to separate them out, right? So yeah, there's a good chance that that person could test positive, but what if we move them quickly and they don't end up getting COVID? So the principle of rapidly moving the positives to a red zone and cohorting the yellows are really important, the exposed folks in the yellow zone, to reduce the likelihood that your numbers are going to continue to increase. Dedicated staff for each zone. This is hard. I've found, and I didn't even know what PPD was at the beginning of this grant. So, but what I found is that a PPD, it needs to be well over 3 if you want to achieve dedicated staffing for each zone. That means that you have a nurse and an aide, or, if it's a small red zone, maybe a nurse that can do both the nursing and duties of an aide for those residents. And that includes having everything back behind that zip wall or in that unit, med cart equipment. You don't want to be moving laundry or dirty trays in and out of that unit through yellow zones and green zones, common spaces. So having the dedicated staff for each zone is really critical. The next one is appropriate PPE supply and the type of PPE that you have. And we'll talk about this a bit more. But as I alluded to before, the astronomical amount of gowns in particular that our buildings need to go through to use gowns in a conventional way. That means put on a clean gown, go in, provide the resident care, take it off, and either launder it or dispose of it. When you have 40 people, 9 touches per day, that's 360 gowns a day, and you can do the math. You're up around 1,000 gowns a week. That might be as much as you bought and need it in 6 months in your homes in normal times. And then lastly, a dedicated and continuous infection control process with measures, a director of infection control. A lot of you have IP nurses, but what we found is when there's crisis, they get pulled to the floor, or, they're handling other administrative roles and they're not able to go out onto the floors and reinforce the proper use of PPE. And we all have PPE fatigue, wearing it correctly, not touching it, doffing it carefully, that we're finding that not having that dedicated person also creates opportunity for more transmission, both for your staff to become infected, as well as the residents. And so those are the 5 critical elements that we have found are absolutely necessary to bring the outbreak under control. And if any one of those are not as optimized as possible, the outbreak tends to go on longer than we'd like to see, because we just know they all kind of work in concert, and doing 1 or 2 of those things alone does not fix all of the problems. Next slide. So just to dive a little deeper into our key elements. So what I've observed is that almost all of our nursing homes have lab contracts. Many of our personal care homes did not, but the turnaround times were highly variable. Many of our homes struggle to perform facility-wide testing of residents in a point prevalence survey type of way, which means you get it done within a day or 2. Rolling testing is very problematic because you're always chasing the numbers. So having a single day or 2 where you obtain those tests allows you to quickly get a snapshot of what's going on in your building and cohort. We've also seen, as I mentioned before, delays in testing due to not having supplies on site at the time of an outbreak. So being able to order supplies in advance from your supplier, so that if you did have an outbreak, you wouldn't be waiting on a shipment to come, is very important. And then more recently, and this kind of happened after the RRCHP started up, point of care antigen testing became available. There were a lot of questions around that. Some of it had to do with the reliability of the point of care antigen testing. Some of it had to do with the manpower required to enter in each test into NEDs if you were using this type of testing in your building. And for many of you, it was a favorable option because of the financial burden required when you do PCR testing on all of your staff. And so, we found that many sites just really struggled with the concept of doing the frequent testing with PCR because of the employee costs associated with it. Most commercial payers are not covering employer mandated testing. And obviously, if the employees aren't paying for it, that cost falls onto the facility. Some of the things we've been able to assist with, so we established contracts with a few commercial labs, and what that allowed us to do through the RRCHP was pay for all of the employee testing and any resident testing that might get kicked back because the resident is not covered. We were also able to set up testing teams to go out and assist with testing at the site at the time of an outbreak. Sometimes those were our own internal teams, sometimes they were contracted through agency, and sometimes they were the National Guard. Some things that I offer for facilities to consider, if you don't have an established testing team, perhaps you have a couple of your nurses designate it so that if there is an outbreak, and maybe they do administrative work normally, but not the DON or the infection preventionist and people that really need to be involved, but perhaps an RNAC or someone who could step away for a day or 2 to do the testing. I make that suggestion realizing that may not be feasible for many, but really think about how do you accomplish testing in your building if you need to do it on a weekly basis and you need to get it done within a couple days. Another item to consider is keeping the supplies on site so you can do the full house testing when you need to, and really try to stick to that 1 to 2 day time frame. Somebody fix these, they look really cute. Thank you. with the figures. So observations of concern. So many sites have limited REN-zone capacity. So when we would go out on our normal site visits, we would say, oh, so red zone B. And if you ever had an outbreak, but the challenge became And I'm sure due to business decisions, the beds become filled. And then when you have an outbreak, you have nowhere to quickly establish a red zone, or the red zone becomes wherever the person was that tested positive. And it's not always that it's in an ideal site where we can do the dedicated entrance and exit, break room, bathroom. Many were placed in areas where they couldn't expand the red zone. We've learned having 2 red zones is a really, really bad idea, and avoid it if you can, because it requires then twice the number of dedicated staff to those zones. And so, you know, these are the things that when we've gone into sites with outbreaks, or even when we've done our normal visits, we got a little nervous because it was kind of clear that we're rolling the dice a little bit, kind of hoping you didn't have an outbreak. And then when it hit, the circumstances weren't optimized because, you know, we're trying to keep our, you know, beds full. And I totally get that. It's my normal line of work. But it kind of puts you in a challenging position then to try to move people. Next slide. So I will often, you know, ask the administrator in the building, you know, to consider weighing the business case of keeping at least a few rooms in that designated red zone open, which is kind of like antithetical to, you know, what we do. We fill beds in nursing homes. Until we have better remedies for COVID, like a vaccine, like therapeutics, one of the most impactful tools we have are to move patients to a dedicated zone. And when there are delays in that, it can lead to a larger and longer outbreak. You know, and I recognize when we are sitting on the phone or sitting in front of you saying you need to move these 12 people to a zone, we have no idea how much work that takes. It is a huge undertaking to move that many people into a red zone. Probably you're moving people out of where the red zone will be. And so I say that recognizing that behind those words is hours of work. That being said, that is also why, you know, reviewing on a daily basis where you're at in terms of your capacity, where is your red zone, where would you be able to grow that red zone, should you have an outbreak or should an outbreak increase, is really important. The other thing that I found is that tripped some of our sites up was assuming that when you had one positive resident that it was going to stay just one. COVID is very sneaky, and it's rare, although I've seen it a couple times, but rare, that you just have one case. And so you always have to be planning a few steps ahead of it to keep up with it, so that you're not kind of caught on your heels trying to catch up with an outbreak, especially when it comes to moving residents. And then I've had this conversation a lot of times, and I know a lot of the owners of the homes don't like me when I say this, but I still stand by it because I think it's better for the staff and the residents that are already there and the people that are coming in. I think you have to strongly consider holding new admissions. If you don't know that you can safely protect them, if you still have a blossoming outbreak with, you know, with activity in other areas of the building, you don't know what kind of risk you're going to expose those folks coming from the hospital to when they arrive in the building. And also it could create a situation where you don't have the beds to establish an adequate red zone. So every home is different. That may not be the case in every place, but especially in homes where you're kind of like, you don't know that you quite have it under control yet. Holding the admissions, one, to give your staff a minute because the staff become extra stressed in this case, as well as ensuring the safety of the current residents as well as the people coming in. Unless you are 100% confident you have it under control and the residents that you're admitting are going to be safe and not likely to be exposed. Next slide. Dedicated staff for each zone. So some of the observations we've had are, one, staff are often vectors, usually because they're asymptomatic. But also I find that they touch their PPE a lot. So we'll go in and they're touching the front of their masks, you know, pulling up their shield, or goggles are popped up on their forehead. At some sites, walking in and out of resident rooms with gowns on. Staff crossing between zones equally is of high risk, especially during the same shift. So what we found is that if a nurse has to cover both a yellow zone and a red zone, the movement between the two is highly dangerous for the residents in the yellow zone. And we worry about that staff person and their meticulous use of their PPE and hand hygiene so that they don't cross back over to the yellow side and contaminate a yellow zone with coronavirus. The other thing that we found, and honestly, I learned from some of our outbreaks, because I didn't really think of it, the med carts. Not every facility has an extra med cart sitting around to put into a red zone. So having some sort of locked med cart that you can use for a red zone is really important, as well as the equipment. Again, anything that you're sharing in between zones just increases the risk for transmission. And then lastly, this becomes a real problem, dedicated break room, bathroom, entrance, and exit. In many of our sites, we've had to recommend resident rooms be used as a break room because there's a bathroom in there. Somewhere, a clean space for the staff member to take their breaks. We don't want people that are taking care of the red zone folks to be having breaks and using the same bathroom as the yellow zone staff, for example. Some of the insights we found is, like I said, a PPD lower than 3 is just not gonna, it won't cover your needs to have dedicated staffing in each zone. I already mentioned about accepting new admissions if you're struggling with staffing in the setting of an outbreak. If there is routine crossover of staff between the zones, you're likely to see ongoing transmission. And really, my recommendation for the ownership and the owners and leadership is to plan to staff at a 3.2 or higher during an outbreak. And that may mean that they need to have kind of a go team, or one site called it their dream team, that they would pull together when they had an outbreak to go in and support the building. It's not only the resident care, but the DONs are just overwhelmed. The administrators are overwhelmed with the amount of work that needs to get done. Even just, I can't even imagine what their lists look like. And even the action of delegating and then making sure it happened is overwhelming. And so having that backup person, someone that, you can team up with and has that same level of skill as an administrator or a DON, or even extra nursing supervisors, can make all the difference. And what I've really noticed is that when the leadership, the DON, NHA get really stressed out, things start to fall apart. And so as much as we can do to stabilize the needs in the PPE department, the staffing department, to have people to delegate to, that allows them to kind of be clear-minded and manage the building through the outbreak and take care of themselves, because I know some of them are worn ragged until they get through the outbreak. They're just exhausted. Next slide. PPE. So one thing that we've noticed a few things. So are still using gowns in the yellow zone in a crisis capacity. I'm going to talk about this more specifically in a little bit. But the reason that is not encouraged is because it increases transmission to the residents in the yellow zone and the staff, especially if they're being asked to redon them. So I've been using the analogy, and I think it kind of resonates, is if you went into a room with a resident who had C. diff, you'd put on a clean gown, you'd go in, provide the resident care, and you'd doff it. I don't think any of you could even imagine walking around the unit or going even to the next resident room with that same gown on. Yet, when we were in crisis mode, this was what we did because we were in crisis mode. These were, back in the early months of the pandemic. What has happened, though, is that we've gone from crisis mode to this is somehow what we should accept as being standard of care, which it's not. So oftentimes what we've seen is that we're still using that strategy for gown use when we know that it's not ideal and can both expose the staff to risk as well as the residents for ongoing transmission. There's a huge cost associated with that. And as I alluded to before, I think that is probably one of the areas where we have found the greatest need, and I can respect that is, the amount of gowns that are needed is just unlike anything that most have experienced during their careers prior to COVID. And, the other is the N95s and mask fit testing. So this HON came out during our program. It was not in existence prior to the formation of the grant. And so to be honest, and this is probably just me being not cognizant of what was coming down the road, when the grant started, we didn't realize that mask fit testing was going to be something that the RRCPs would be asked to do. And so, we've been able to find a couple of mask fitting teams, but this remains an ongoing need for sites. And, even in many hospitals now, they're moving to unit-based they have some trained on each floor to do mask fit testing. And I think similarly, what we're hoping to do, especially with our larger sites, is train the trainer, get you a test kit, and have your own internal way to mask fit test, because with the varying supplies of N95s coming in, it's going to be an ongoing need. And it's really expensive to do that if you have to contract someone to come in and do it repeatedly. Having your own ability to do that, to provide good respiratory protection to your staff, is really critical. So just some of my insights. What I found is there's a lot of variability. We have some nursing homes that have had no troubles with procuring PPE, even during outbreaks. They've been good to go, all set. And then others that really, really struggle. And I don't know what the barriers are. I don't do operations, but I do notice that it's not every site that struggles. And most of you who have worked with me during outbreak know that as we're sending you PPE, I'm also nudging your administrator and your corporate to keep working their angles as well. But the fact of the matter is, in an early outbreak, while I'm saying that, I know that the need is immediate, and so we calculate that depending on your yellow zone size, we estimate 9 resident touches per day, and that's how we calculate what your daily PPE need would be for the gowns. And then I multiply that by 7, and that's usually the shipment you'll get from us, with the hope that you'll be able to find additional. But I know there have been many cases where we keep that up for a few weeks until you're able to secure them on your own. Reusables are awesome too, but I know they're becoming hard to come by again. And then again, the N95s, the mask fit testing offers the best respiratory protection. The one thing I would say, and I've had some in-depth conversations with a few administrators and DONs, is that there is an approved list that is acceptable of KN95s, but I don't think there's any disagreement that the N95s that are mask fit tested provide your staff the very highest level of respiratory protection, and that's what we should strive for. So when I see the KN95s, it's not that they're wrong, especially if they're the KN95s on the appendix list, but they're not the best. And, we want to protect the staff. So we're always trying to push to get the right supply of N95s and mask fit testing, so we have the best respiratory protection for your staff. Next slide. Infection control. I kind of talked about this already. The infection preventionists are like Wonder Women, Wonder Men. They do all sorts of things in addition to their infection control roles. But in all honesty, in the setting of an outbreak, they're needed in lots of different ways. And you do need like 4 of them, I think, to really be effective, because they're the ones that probably should be doing the line lists for the staff and residents, checking to see who can come off precautions, creating heat maps, etc. Not to mention all of the infection control needs of the building. The application of the HONs in practice tend to lean towards crisis mode too often, even when it's not close to ideal. And so in the HONs, what we found is that because there are references to crisis, contingency, and conventional use, we're all kind of still leaning towards that crisis mode, and we want to start moving towards the conventional mode because we know that is going to be the best way to protect the staff and the residents. And the other thing I think we've noticed, just the correct use of PPE in zones and the staff compliance with it, and the cleaning and storage. So that's been one challenge, just where the staff are keeping their masks and eye protection when they're not at work. They should not be leaving the building with it. They should be stored in paper bags you know, somewhere in the facility where the staff can come in and put them on. And we've seen that in many sites, but in some sites not. That's kind of it. Either they had it and it deteriorated, or they never had a need for it. So it was kind of a new thing when we proposed it. Some of our insights. So when you have an outbreak, creating a heat map to know exactly where your positives are, creating your line lists and tracking becomes really important to facility flow. So what you don't want is to have, you know, 40 people in a red zone for 25 days when they could have moved out after, you know, 40 of them could have moved out after 10 days or 14 days, especially if you have more positives coming in. So it's really important that you're tracking when they were tested and were positive, and when they can come out of precautions, if they have symptoms, if they don't, so that if you do have additional cases, you can move them out of the red zone, bring the new ones in. Large facilities we found with major breakdowns in infection prevention measures often need an IP on each unit for several hours each day to reinforce proper PPE practices. The staff, I think I've seen largely will do what is asked of them, but they do need reinforcement because old habits are hard to break. And so if they've been taught it one way, and now you're saying, no, you shouldn't wear a gown all around the unit. You have to take it off after each time, before you come out of a resident room each time. That can be a hard habit to break. It may be that it's not that they don't know, but it may take a few reminders before they implement it on a routine basis. The other thing we've noticed is COVID-19 is highly disruptive to normal processes. So facilities who don't maintain a high level of preparedness have the most difficulty when the outbreak occurs. So again, it's when you get to breathe that sigh of relief when you don't have an outbreak and processes start to break down, getting all of your staff to start moving back in that mode of high vigilance that should have been maintained the whole time can be really hard to do. And so, you know, my insight is sites should behave as though every day has a potential for an outbreak. And so thinking about your zones, your PPE, your staffing, continuous reinforcement of IP practices so that you're not flat-footed if it does occur is super important. Next slide. Okay, and just a few comments on the evolution of PPE, and I've hit on this already. There was a time where we were all in crisis mode. I had buildings wearing raincoats, ponchos, all sorts, hospital gowns, without sleeves, and then making their own sleeves to put on. I mean, it got really, really bad. We're not there anymore. And if you are, one, I challenge your supply chain. 2, reach out to us so that we can provide you with some additional vendors. And 3, obviously, if you're in an outbreak, we want to know, because we don't think that's acceptable, and we'll send you gowns to, give you some time to procure your own. But I think, the message should be it's not okay anymore, that there are resources out there, and we all need to be moving in that direction. The other piece is the N95. So really N95s in the yellow and red zone. We're still not seeing that fully, particularly mask fit tested N95s. And again, that is a direction we should be moving in to provide the highest level of respiratory protection for your staff. Next slide. So again, just because I have a little audience here, conventional yellow gown usage is a single gown per resident care episode. No more moving room to room with the same gown on. I also get really nervous about staff that come out of the resident room to work at the med cart with the same gown on, that they're going to contaminate their workspace on the med cart and then transmit it to themselves. So I also really caution them about coming back to the med cart with the gown on, and if they do, they need to wipe that whole med cart down. And then I already have the calculation for what you can expect in terms of gowns needed. Reusables are the way of the world if you can get them, because the burn rate is crazy when you have a high number of folks in the yellow zone. Next slide. And then I think this is my last slide. Again, the N95s, acceptable is acceptable, ideal is ideal. I think that we should all be striving to have the supply of N95s we need to have all of our staff on the yellow and red zones mask fit tested so that they have good respiratory protection. If you don't, these are another area where between vendor lists that we have and some new supplies we're getting in terms of N95 masks, we'd like to assist. But again, this is another area where early on, there's been a lot of learning. First it was, oh, you can wear a surgical mask, maybe some eye protection. Then we moved to eye protection. Now we really know, you know, you need a high level of respiratory protection with this virus, that they can be airborne. And particularly with our older adults, many of whom have a cough, can have aerosolized viral particles. And so we want all of the staff to be as protected as possible. I think that's my last slide. I'm happy to take questions or comments.
So thank you.
Question here about the medical questionnaire for facilities for fit testing. So I've had some folks ask me, I am not an occupational health physician, but I do know there is a required form, and there are individuals that you may need to work that cannot be mask fit tested. There are certain conditions that really make you not eligible to wear an N95. I know there are some respiratory conditions for sure. Also, if you're bearded, you can't mask fit test someone who has a beard. And I've had questions about, can they sign a waiver to just say that they know they can't be mask fit tested because they don't want to shave their beard? And I said, I can't answer that question. I guess that's an HR question. But yes, there is a questionnaire that comes along with the mask fit testing that is normally reviewed. In the setting of this, the emergency declaration, I don't know that they have been strict with it. But that being said, I think you do have to look at individuals at your workplace who may have medical conditions that make it such that they can't safely wear an N95 for the entire shift. And the last thing we want are for people to be touching the front of their mask and like lifting it up to get air during their shift, because I tell the staff, just consider the whole front of it contaminated. You don't want to touch any of it. You don't want to touch your shield. You don't want to touch your mask. And if you do, you got to wash your hands. But your PPE protects you, but it's also dirty. And so we don't want to put PPE on people and then have them touching it, especially if we know they're really not suited to be able to wear it.
Nikki or Aisha, do you have any questions for anyone in the group?
I mean, I know I have some pros on here because I see some of your names, and I know there are many of you that are managing or have managed an outbreak. You certainly don't have to share if you don't want to. But you know, one point I made at the beginning of this, and I just want to make again, is that I have not gone to one site where I have found the administrator, the DON, working 24/7 to bring their outbreak under control. What we often find is that there are it's resource challenges and just the constant keep up with the staff in terms of the PPE use and how they're moving around the building. That is hard when you're also trying to manage those other things, like making sure you have staffing, making sure you have PPE, you know, communicating with the families. There's so many responsibilities on the DON and administrator that, you know, you very quickly can become overwhelmed. And I've been so humbled by the hard work we've seen from our DONs and administrators. You guys are all to be commended for all the hard work you do. Trust me when I say, I know it's very easy for me to sit and say, you need to move these people, you need to do this. I get all the hard work that goes on behind the scenes to actually execute that. And you guys should know that we see that as well. So I hope that when we're making these recommendations, that you know that we're really honored to be working with you, and we know you're working really hard to take care of your residents and staff.
There are two questions in the chat. Can you see them?
Yeah. So the first one, how can we find someone to train the trainer? Yeah, so right now we have one, and we're working on bringing on our second group that can train the trainer. I was also able to just recently, we were able to purchase about 20 kits for mask fit testing. So the hood and then the saccharin spray. So if, I think most of you I recognize, but if you shoot us an email, we're happy to connect you with one of our vendors. And then if you don't have the supply to do your own mask fit testing, mention that as well, and we'll put that order in with our supply chain. Now, I only have 20, so if I run out, I do have the option to buy the bitter spray, which I think is equally fine, but I didn't purchase. But we'll place an order for more. I would love to see most of you be able to do your own mask fit testing on a rolling basis. I think that it's one of those tools that no one ever required nursing homes to have, and then all of a sudden it's like, hurry up and do this, and the resources are really limited. So yeah, and I think my email is probably shared. You can certainly email me directly, and we'll get you hooked up. Was there another question related to that? Hi, Anne. I think I have, I was going to say, I think I've emailed you before, so I can certainly reach out. From Cross Keys Village. Chris mentioned, we have heard that OSHA has been citing communities in the Southeast region for not having staff fit tested correctly, regardless of the declaration. We don't have a physician who reviews the questionnaires. WorkNet, I believe one of the one contractor, second one coming on, I believe does. And actually I was just on a session at noon with our other RRCPs, and they weren't enforcing it, but now they are. So it is possible that will come up on the testing. So they're pretty serious about it, which is also why I'm urging the use of the KN95s is difficult because we don't match test on KN95s. So that's also why the N95s are really important. Yeah, and Chris says most workmen's comp insurance providers have a person that can train the trainer for fit testing. Yeah, I mean, I know a couple of our homes, I think he might have hopped off, even contracted with local occupational health groups to do their mask fit testing. So, you know, if you have a vendor, I mean, WorkNet is a vendor that's out there in the community. There are a number of others out there as well. You know, this is something that can be really costly though. So again, if you can get train the trainer in your own kit, it's going to be a more economic way to achieve the objective. And it's not difficult from what I'm told. And I know if the guard ever comes to your building, they'll train the trainer for you as well. And maybe if that's something that's in great need, I can see if we have internal resources as well to help with that. We may not be able to do on the Penn State side the fit testing for your staff, but we could at least train, you know, do the train the trainer piece. Any other questions? Anyone disagree with anything that I offered?
Nikki, I have a question. Can you hear me?
Yep.
Well, first of all, thank you for sharing that amazing insight that, you know, your team has built in a moment of crisis. So I'm going to a more simple thing. How effective is temperature screening for employees? Have we wasted our time and resources, or has it helped?
You know, that's a really good question. And actually, I chuckle because it's not only the temperature screen, but the questionnaire, because now sites are saying, well, what about with the flu? Everybody's going to be excluded from work, you know, because they have, you know, symptoms due to a different thing. But how are we going to handle that? You know, the screening came about because we didn't have the testing capabilities. Whether or not they changed the requirement for the screening, I don't know. But I think your point is well taken. In conversations we've had, and I don't have any studies that show this, I don't know how effective temperature screening is. I think the vast majority of staff that have been positive become ill during their shift. I don't know how many have been caught by a temperature screen at the beginning of the shift. I'm sure there were some, but I don't think that's the vast majority are asymptomatic and test positive just on surveillance testing, or they become symptomatic during their shift or like after they've worked a shift prior to their next shift. And so we haven't found that to be a great remedy. And I wonder now with testing if there'll be a balancing of that, because it is, you know, it's an extra step every day for, you know, hundreds of staff that would have to report to work.
Yeah, just learned it the hard way that I walked in with COVID, not knowing, with a normal temperature.
Yeah. Yeah. Yeah, because most of the staff are not symptomatic. And that's the hard part with COVID. Many people don't have symptoms. They may develop symptoms, but when they, you know, are probably more contagious, you have no symptoms. So it can be really tricky to rely on a temperature check and a screening question as a way to know, feel pretty confident that the person, you know, doesn't have it. Any other questions? Thanks, Aisha.
All right, well, in the interest of time, we can give everyone 3 minutes back in their busy days. If there are last questions, go ahead, put them in the chat, and we'll respond via email. Please remember that you can claim CME credits for today, and the evaluation link will be sent in a follow-up email. If you're not claiming CME, please still complete the evaluation, as it helps us to continue to improve our sessions. And finally, we hope to see you again at the next session 2 weeks today, November 9th at 2 o'clock, when Dr. Christina Newport will discuss symptom management for end-stage COVID. So thank you, everyone, for your engagement and participation.